Right. Well, welcome everybody. Welcome to our bi-weekly webinar series called Sight and Sound Bites. Is coming to you from the Eye and Ear Foundation. This is our new bi-weekly lunchtime educational webinar series of the Research and Clinical Innovation at the University of Pittsburgh School of Medicine. Today's topic is head and neck cancer survivorship care, progress made and opportunities for improvement. I'm excited about today's topic. This is a project that I know we're all very passionate about, and we certainly know that it really impacts people's lives in terms of what we're learning regarding survivorship. So I'm Lawton Snyder. I'm the CEO of the Eye and Ear Foundation. The Eye and Ear Foundation supports research to advance care for vision, hearing, balance, voice, and cancers of the head and neck. We work closely with the two departments of ophthalmology and otolaryngology at the University of Pittsburgh. The funds we provide annually to these two departments stimulate and advance groundbreaking research. You're going to hear a lot about that today. And that support is only possible because of philanthropic donations. So we really want to thank everybody who has supported us and helped us over the years. Before we start today's program, I need to go over a few housekeeping items. So I know a lot of us are doing Zoom meetings. This is a Zoom product. It's the Zoom webinar product. It is a little different than maybe when you're Zooming and chatting with your family. The chat function is not available on here, so don't even bother trying to click on the chat. If you hold your mouse down at the bottom of the screen, though, you will see a Q&A bubble. So we are keeping the Q&A open. We want you to ask questions. How this will work, though, is we'll hold the questions until the end. So, but you can ask questions at any time during the presentation. If something comes to mind, just type it in. Just click on it and type it in. Tomorrow, you're going to receive a survey via email to provide us with feedback. You'll also be added to our email list to receive future webinars. So today's topic, as I said, is head and neck cancer survivorship care, progress made and opportunities for improvement. Today's speakers, Dr. Jonas Johnson, Chairman of the Department of Otolaryngology at the University of Pittsburgh, and Dr. Marcy Nielsen, Assistant Professor in the Department of Acute and Tertiary Care in the University of Pittsburgh School of Nursing. Thank you both for being here today, and thank you for today's presentation. Dr. Johnson.
So thank you, Lonnie, and good afternoon to everyone. Welcome to this webinar series sponsored by the Eye and Ear Institute Foundation. So as Lonnie said, my name is Jonas Johnson, and I'm here with Dr. Marcy Nielsen. We, as is common in the world of biomedical science, want to announce that we have no conflicts of interest, which we need to disclose to you. Some years ago, the Institute of Medicine defined an individual as a survivor at the time of diagnosis of cancer. And then you remain a survivor for the rest of your life. It is becoming increasingly important and acknowledged that living with cancer and its treatment can have multiple effects on you, your physical health, your mental health, certainly your emotional health, as well as your social well-being, and it has an effect on financial effects. We're going to be discussing with you as we go forward. So the cornerstone of survivorship care is outlined on this simple slide. Now, surveillance is something that I think cancer doctors have been doing forever. That means give you a checkup and determine if the cancer is still controlled. Prevention acknowledges the fact that roughly 20% of cancer patients may experience a second cancer during their lifetime. So we like to counsel people on the prevention of second cancer. Now, what's new, I think, in the last decade has been the coordination of care and then the management of the cancer-related side effects. That is, the things that develop after a person has been treated for cancer. So the American Society of Clinical Oncology wrote some guidelines actually in 2017, and they said cancer care needs to be team-based. It was also pointed out that there can be a variety of approaches to cancer care. What we've decided to do here in head and neck, that is cancer of the throat, is have a multidisciplinary clinic, which is disease specific, which means that we limit our care to people who have cancer in their neck and their throat. Our clinic was founded in 2016, and it is multidisciplinary. Currently, we have 9 disciplines represented, which includes nurses, an audiology assistant, a speech language swallowing expert, a physical therapist, a dentist, medical consultant, a dietitian, and a behavioral health person. All of these individuals can help patients who experience cancer-related side effects. The essential component of the clinic that we've developed is that you can see these 9 people in one visit, you see them in one place, and you pay only one copay.
So I'm going to talk to you a little bit about what we've seen through our clinical research in terms of late and long-term treatment effects. And long-term treatment effects are something that occurs during treatment and persists, and later things that develop down the lines, maybe 2 to 3 to 4 years after you're finished treatment. So the American Society, or the American Cancer Society, has provided healthcare providers with a list of things that can happen after treatment. And you can see the list here. When I first looked at it, I thought it seemed fairly inclusive. It was detailed, but I can say now, working with survivors for years, that there are things that really we still need to investigate and we still need to learn about because they aren't noted on this list. And so one of the ways that we ask our patients how they're doing is not just through assessment, but also through patient-reported outcomes. And patient-reported outcomes are measures that have been proved to be valid, so it means they've been tested and they do measure what they're intended to measure. And so we give our patients several of these to get to what we know is some of the most prevalent issues that patients experience. And so since December 2016, we've seen about almost 1,000 unique patients, and that's actually calculated into almost 2,000 visits because many of the patients come and see us more than once. And 93% of those patients say they have at least one late and long-term effect that they experience after their treatment, and 54% say they have 3 or more. And so this is from survivors that have been treated anywhere from a year to 40 years ago. So these things can still impact patients on an everyday basis. And what our patients report through these quality of life patient-reported outcomes measure is that swallowing, saliva, and pain are our top 3 issues that patients experience. And this is actually never really changed. So the top 3 haven't changed since we've looked at the data 1 year, we've looked at the data 2 years in. These still remain the same, and the percentages are almost exact, which has been very fascinating to me. So I think it really is representative of what our patients experience. And so as I mentioned, the first was swallowing. So swallowing trouble or problems with swallowing is called dysphagia. And while you see about half of our patients reported as a major concern, actually more of our patients have symptoms that indicate that they're not swallowing safely or effectively, and that's about 74%. And this graph, if I can show you with my pointer, the purple line, so that's actually swallowing symptoms or symptoms of trouble swallowing. And what you see right after treatment is that patients have a lot of trouble. And then this actually shows that the symptoms start to improve and get better, but at 6 years, we start to see this downturn, and this is statistically significant. And so patients then start to report more trouble swallowing. And so Dr. Johnson, what would you hypothesize is related to that change or downward turn?
So this spline in the curve is attributable almost certainly to fibrosis or scarring. So what happens with treatment is people have surgery or people have irradiation, and those treatments represent an injury to normal healthy tissue. And over time, the healthy tissue becomes stiffer or more fibrotic. And this is really frightening because after 6 years, many people are reporting to us that their symptoms of dysphagia are actually worse and or worsening. And it's really a call for action.
So this changes in the tissue don't just affect the swallowing mechanisms, but one of the unique things that we've seen in our clinic is what we term as neck disability. So neck disability is actually pain that changes how a person functions or impacts how they function in terms of daily activities, like driving or working or reading. And so 55% of our patients report some degree of neck disability, with most being mild to moderate. We don't have many patients who report severe to complete. And what we see here, so this is just a manifestation of what neck disability may look like in a person. It can change your posture, it can bring your head forward and down, it can limit your range of motion in addition to causing you pain. And what we found really interesting is that when you look at surgery alone, patients do have a risk for developing neck disability. But when you look at patients who have chemo and radiation and have never had surgery, they actually have 2 times, almost 3 times higher rate of neck disability than those who have surgery alone. And so I think this is really surprising to some of our patients, and I've talked to many of them when they come in and they say, you know, I think I slept on my neck wrong, or I've tried 10 pillows and none of the pillows are working for me. They just see surgery as a very invasive action. You know, you're cutting into the neck or the jaw and you're taking tissue and lymph nodes, but they don't seem to see or feel that chemo and radiation is as invasive, but it really does change the tissue and can impact how you function. And so surgery and adjuvant treatment, which is surgery and chemo and radiation, actually doesn't have more of a risk than non-surgical treatment or chemo radiation. It does have a higher risk when you compare it to surgery alone. So those two groups of patients do have a greater risk for having neck pain and spasm. And this can impact their quality of life, not just physical quality of life. You can see this points here, about 20 points lower, but they can also affect the social emotional quality of life. When you have pain and you have limited movement, you may not want to go to dinner, or you may not want to be active in some of the things that you used to do. And so all of these symptoms and late effects don't really appear alone or in a silo. They can actually kind of counteract or be associated with other issues. And that happens when we look at neck disability and swallowing trouble. So when patients, the symptoms of swallowing dysfunction start to increase as the severity of neck disability increases. So in this chart, you can see that here is the mean score for trouble swallowing with somebody who has no neck disability. And then you can see when you get to the moderate to complete, how that just continues to kind of linearly increase. So Dr. Johnson, what would you say in terms of research, what would be our next step in this area of how a neck disability and swallowing trouble interact?
So this is a front and center in terms of our efforts that are currently ongoing. We discussed briefly a few minutes ago how swallowing seemed to get worse after 6 years. So neck disability runs with dysphagia. That is, they're probably both due to scarring, fibrosis, and stiffness. So we would love to know how to prevent fibrosis and scarring, and then we'd love to know how to reverse it. So we're making, on everyday basis, increasing efforts to help people loosen up scars and keep scars as flexible and limber as possible. At the same time, we're working with scientists because we would like a new biologic approach. We could imagine that sometime in the future, there may be a medication that we could use that would help people, and it would help them not just with their swallowing, but with their neck disability as well.
And so one of the notes under the survivorship definition is that cancer care can, in the cost of cancer care, not just during treatment, but after, can really impact patients' financial toxicity. So this is really just a new term for an issue that's been going on for a while. We've termed it financial burden, financial distress. It's come across as a lot of different words, but what it means is that the cost of your cancer care and subsequent costs related to maybe your physical rehabilitation or medication can really become burdensome, and this can have poor outcomes on patients. And so one of the studies that looked at our patients showed that patients who are married and patients who have greater than a bachelor's degree seem to report less financial trouble. But one of the interesting things that needs to be explored more is that it does seem to differ by site. So oral cavity patients had less toxicity than those who had cancer of the larynx and hypopharynx. And so what really needs to be done is we need to look at this across the trajectory. So before treatment, after treatment, and years down the line. We do know that head and neck cancer patients seem to have more out-of-pocket expenses related to their cancer care than other cancers. And when we look at our patients, the burden is high. So about 40% of head and neck cancer patients report some financial burden. And this causes them to have to use some of their savings, their retirement, and most have to use, or some have to use more than one mechanism. So they may have to use their savings and loans and credit cards. And so I think as providers, this is a hard topic for us to talk about because there's not really the best answer, but it is something that we need to discuss so that we can try to help you better address your symptoms and needs.
So this graph is a demonstration of efforts being made by Dr. Nielsen and myself to understand how provision of survivorship care may impact health outcomes. So this is a reflection of time, which is on the horizontal axis. And the blue line are people who did not come to the survivorship clinic, and the red line is people who did. And as you can see, people who came to the survivorship clinic in the red line seem to demonstrate a reduction in inpatient admission, that is hospitalizations. So we would interpret that as good. The other thing we noticed when we looked at these data is that during treatment, which is, radiation generally takes 35 days, but during treatment and shortly thereafter, which is the far left of your graph, there's a very high rate of hospitalization. So we were looking for efforts to change this. So these data, which come from patients treated between 2010 and 2012, indicate that during irradiation, with or without chemotherapy, roughly 35% required hospitalization for dehydration, nausea, vomiting, or mucositis. So we moved forward and we have new data from Pitt. This is on 542 patients treated between 2016 and 2018. And once again, about 35% required admission for dehydration, pain, and weight loss. So the question is, what can we do to fix this?
So one of our new efforts is something that we call the Enhanced Care Trial. So the aim of this study is to really evaluate the effects of symptom assessment intervention on hospital utilization and patient quality of life. So the sample is patients who had radiation for squamous cell carcinoma. So that is the most common histology that we see in terms of cancer type in the oral cavity, oropharynx, and laryngopharynx. So those are just the three sites we focus on because those include most of our patients who are diagnosed with head and neck cancer. And it's being done here with partnership from the Department of Surgery with Hillman's Medical and Radiation Oncology. And so the intervention is the utilization of a nurse navigator. So the nurse navigator is Deborah Pickford, who many have met in their care, but she now goes over to Hillman and sees patients in radiation oncology and asks them about their symptoms twice a week. We do it on a Monday because most of the patients see their doctors on Tuesday, so they have an update. And we do it on Thursday in hopes that if something's changed drastically, we then can deal with it before the weekend. We also have the availability of a speech language pathologist. So the speech language pathologist reinforces strategies, can ask and do a quick swallow eval at the bedside or chairside, and can plan for other interventions. So this has also helped us increase the involvement of many other providers, including dietitians. So the dietitians at Hillman are made aware they can come in during one of these intervention visits to help provide supplements or give advice about things like nausea or vomiting and foods to avoid or to try. And so the coordination of the oncology team is really something that has gone well. So at the end of the day, Deborah sends a note for each patient to all of the providers. So all of the providers know if the patient is having more trouble so that we can either address it really quickly. If they are dehydrated, we can get them in to have IV fluids. And so it's been a new intervention. We started in January and we've recruited 22 patients. We had a little blip in the middle, which was COVID-19. And we are addressing and dealing with some of the things. And I think it just helps make the intervention stronger. And so stay tuned. As I mentioned, we're only 22 people in, but we hypothesize if we can do a systematic symptom assessment and manage these symptoms through enhanced care coordination, that we can decrease hospital utilization by 15% and improve the patient experience. And so this would help provide us a new model of care, which could enhance value to not just the patient, but the community and even the organizations. And so as we continue to evolve and learn more, we are continuing to work to better care for our patients. And this does happen through research. And some of our ongoing efforts are through investigating caregiver burden and other aspects that may influence caregiver burden, like health literacy and how they impact caregiver outcomes and also patient outcomes, the influence of radiation on cognitive function. And so this is important also because we are changing some of what we do in terms of treatment with the addition of immunotherapy. And so taking all these variables into account and seeing how this transpires. And one of the newest studies that we're doing is actually comes from really bench, so mice models, and seeing if that actually is what happens and translating it into seeing if our patients experience the same thing. So it's cancer-associated anxiety and whether that affects tumor progression and the exacerbated pain that our patients experience. And so pain, as you saw, was one of our top 3 issues that patients experience. So we really need to find out and dig a little bit deeper into that area. And so in summary, survivors have complex physical and psychosocial needs that stem from their treatment. And these can happen for years down the line. And a comprehensive approach, which really helps us personalize the head and neck cancer care we deliver, is what is needed to address these issues. And then, as I mentioned, we really need to continue to research and explore these issues in order to design and evaluate interventions that can help our patients and hopefully stop some of these things from occurring down the line.
So this concludes our formal presentation. Once again, I encourage anyone who would like to submit a question to use the mechanism Lonnie Snyder indicated at the beginning. We do need to acknowledge with some special thanks some of the funding we've received that helps us support this clinic and helps us to provide this care on one visit in one place for one payment. And that includes the Jack Buncher Foundation, the PNC Foundation and Charitable Trusts, the Beckwith Institute, and then many of you have contributed to us through the Ioneer Foundation. I must also acknowledge that we have had in-kind contributions made by the School of Dental Medicine, by the Center for Rehabilitative Services, and by the School of Nursing. All of these organizations have come together in support of survivorship care. And we are delighted that you've entrusted us with this responsibility.
So I think one of the other groups that we have to thank are obviously our patients, and I think some of them may be watching. We can't do what we do without you, so we are very thankful that you've allowed us to and entrusted us with your care. Many of you have filled out these patient-reported outcomes, which have helped us advance our understanding and what patients experience. And I know many of you have participated in some of the other research studies that we do, and many other activities. Many of our patients have spoken and participated in activities. So we cannot do this without you guys, and ladies, everyone. We really appreciate that you've allowed us to provide you what we hope is really high quality care.
Wow. Thank you both. This is always an exciting topic, and it's certainly one that I know is very interesting in terms of what you're learning and understanding about survivorship. We have many questions already coming in. I'll get to these really quickly. I'm going to start with one though for Dr. Johnson, because I think it's very interesting, Dr. Johnson, that this is something that you're so passionate about, and I know that you are really very passionate about it. So most of your career has been spent as a surgeon for 40 years at the institution, and what really got you to really start paying attention to this aspect of patient care, the survivorship aspect?
Well, I think it's an intersection of several things. I mean, clearly, 40 years on the job allows an individual to perhaps think more deeply about what's going on. The second thing, I think, however, has been my collaboration with Dr. Nielsen, which is far newer. She and I have been working together now for 5 years. And when we started working, we found ourselves increasingly challenged by patients who had demonstrated clearly the burden of treatment. People who are having trouble swallowing, people who are losing their teeth, people who have advanced fibrosis and couldn't turn their head or open their mouth. And it was apparent then that we could do a better job. And what we've tried to do in these last few years is to move the needle in terms of understanding the burden of cancer patients, specifically throat cancer patients, and then try to find ways to meet their needs. So it's a challenge, and it's imperfect, but it's something I think that's worth doing.
Okay, well, we'll get to everybody's questions here, and we do have a lot, so I better get started here. So number one, what is your pathway for cognitive assessment and treatment? What type of neuropsychology testing is being used with your head and neck cancer patients?
So it's actually part of a research study that we're doing, and it's really prompted off some of the work that's already been done in breast cancer. And we're looking at executive function, motor speed, we're looking at perceived cognitive function, and a lot of other domains. So what we've done is we've tested patients right before they have radiation, and because of the tests we have, you have to have a little bit of a time so patients don't kind of learn the test or people don't learn the test. And so we measure that at 6 months right now. And so we have about 25 of our head and neck cancer patients who've done it, and we're actually matching them with controls. So we're matching them by age, gender, and education so that we can see if there is a difference. We're also looking at inflammatory pathways through blood to see if inflammatory pathways can kind of help us predict who may have more trouble.
All right. This question's interesting. I hope this is already happening. Is survivorship being taught in nursing and medical schools?
So,
So,
oh, go ahead. I'll talk
Take
about the
turns.
nursing part.
the reality is, I think, that this is a unique effort here at the University of Pittsburgh. Other people are doing it in other disciplines, such as breast cancer. They're for sure got that started earlier. At this juncture, and we're doing our best to, if you will, teach this to our colleagues around the country and across the globe, because I think that the patients everywhere would benefit if their doctors and other providers embraced the importance and the potential to help people through this kind of an organized effort.
So in terms of nursing school and even medical school education, so we do have a lot of oncology providers in nursing, and it's one of our main focus. So we do talk a lot about survivorship. I lecture to all the undergrads actually about head and neck and specifically about the late and long-term effects. And we have had several nursing students who published and presented at national levels related to survivorship. And even the med students. So I have personally worked with several med students who are doing projects. They're very interested in things like caregiver burden and health literacy, and even how being in different locations, so being in a more rural area, may impact your outcomes. So we are working to change kind of education and highlight the fact that this is a very multidisciplinary care, which is a goal of at least the School of Nursing, is really to help our nursing students know other providers' roles and be able to work seamlessly with all of the providers.
All right. Well, we have a lot of questions to get through here, so I'm going to keep going here. Great that you're planning on looking at the impact of cancer in a loved one or family caregiver. This should be informative. Have you surveyed patients and caregivers about what most helped them through treatment and what they most wished had been available to help them?
So we've done a little bit for the patients, but not as much for the caregivers. And I think that's a great idea. And actually, one of our med students will be investigating that kind of caregiver and patients going forward. So I think those are questions we can ask, and it really gets to helping us. It's easy to fill out a yes/no question or select this, select that, but open-ended questions like that really allow us to just understand more intricate ways that we can help. So I do think while we've done it, we could do a better job, and it's perfect timing because we have a med student who's very eager. So one of the things that I think is important, and it's something that I'm trying to do a better job of, is having patient advocates involved in research. And so part of it is what we call stakeholders. And so I think that really helps us stay focused when we do our research and gives a new angle to things that we should think about.
Wonderful. So what are the latest advances in radiotherapy that may help to mitigate the fallout and lasting side effects?
So there have been many advances made in radiation therapy over the last many decades. So, for instance, contemporary radiation therapy, the head and neck routinely uses what's called image modulation, or IMRT. The idea being to be more precise in what's treated, because when you treat normal tissue, you invariably incite a reaction, and the reaction results in first pain, and then, of course, this fibrosis we've been talking about. So the reality is that in the 21st century, the biggest question that is being entertained by radiation oncologists and other people in head and neck oncology is the following: can we give people less irradiation and still treat their cancers? That is, still effectively treat their cancers? And the answer is, well, maybe. And it's most appropriate in the situation where people have this cancer that's due to the virus HPV. So there's so many things to be done. That's a great question, and I wish there was a great answer.
So this is a friend because he says, "Hi, Marcy and Jonas. Great presentation. It sounds like amazing clinical progress and exciting new research. I'm interested in hearing more about the enhanced care trial. Can you describe more about the content of the navigator intervention and how it is targeted to the determinants and drivers of high healthcare utilization among patients undergoing radiation therapy?"
So the enhanced care trial, we are doing a couple of different things. So one of the things is that the nurse is using a validated symptom assessment. So when she goes in, she has a symptom assessment targeting pain, but also targeting the other symptoms that patients may experience. And so if there's providers on the line, they're probably familiar. So it's the MD Anderson Symptom Index. And so what she then does is compare it to the last report. And so I would imagine if I could draw you a graph, it would probably look like that with symptoms in terms of treatment, and we've seen it. And so what she does is if the patient has a change, especially a notable change, so a significant change we decided was a 2-point change, then that gets reported to the providers. And so with that, there is an expected response from the providers that day. And many times it's the physician assistant or nurse practitioner who then discusses with the oncologist. And so we have been able to get patients in who needed fluids on a Friday instead of having them come into the ER. And so that's what we're really trying to prevent. We are also working on, while we realize we can't prevent all patients from having PEG tubes or PEG tube placement, trying to get that done more in a scheduled fashion than having to come in after days and days of trouble on a weekend. And some of the very other interesting things that I've actually seen are our ability to really address the nausea and vomiting and other aspects through changes with the dietitian, through medications being reordered. So those are some of the things, and I wish I could tell you more, but that's just the close contact of having somebody to call, but also looking at all the symptoms, not just assuming what you think they may experience. And then having the speech language pathologist there also helps because we've been able to see patients who are having trouble and modify, give them strategies, and then bring in the dietitian. So if they have a softer diet, what can they do? And it's a lot of coaching, I guess. I think that's a big, component of it is just having somebody there to tell you you can do it and helping recognizing that the symptoms have changed and what we can do. So hopefully we'll have more. So obviously COVID-19, we had to take a step back and do some of these things over the phone. And I'm not sure it always translates as well over the phone as it does in person.
Okay, well, thank you. I'm going to just, for our attendees, we do have a lot of questions to get through. So I'm going to hold a few of these to respond to you via email. And I see a couple that are more for personal health questions and insurance questions, but we have your email, so we will answer those separately. And I apologize for not putting that disclosure out front. Here's a question is, what is the role of hearing health and audiology services in your model of systemic management at the Survivorship Clinic and Hillman Cancer Center?
So, this is amazing. We didn't pull hearing into our clinic immediately, but Dr. Catherine Palmer, who, as you know, runs the audiology section in our department, came to Marcy and I and suggested that we ought to test people's hearing. And Catherine said, and now this is silly, but it's spot on. She said, Jonas, why do you bother talking to a patient who can't hear you? So she suggested we test their hearing. So over the course of 2,000 patient visits or so, something over 70% of people have hearing difficulty. It's very common. Now, I'm not going to tell you it's all related to their treatment because, people in our society lose hearing with age and for a multitude of other reasons. One of the big problems that we discovered is people had hearing aids, but the batteries were dead. Or they had hearing aids, but they were dysfunctional. Or they had hearing aids, but there was wax in their ears. And so our audiology assistant has addressed all those things. It's been amazing service. And then we even have a gadget that looks much like what Lonnie is wearing right now, which are headphones. And it's an amplification system. So if a person's really deaf, they can put these amplifiers on and they can hear us instantly. It's so cool. I mean, there was a cute story, maybe Marcy, you can relate, about an older man who took some home.
Yeah. So we had an older patient who was wearing it in the clinic. So I will say we screen patients every time they come in the clinic. So the audiology assistant does that. And then if they fail, we offer a full audiogram so that if they need hearing aids, we can work on that process. But this gentleman didn't want an audiogram. He actually didn't like hearing aids, but he really loved the amplifier. So he said he wanted the amplifier. So he bought one, and then he ended up buying a set for his girlfriend so that they could go to movies together. So it was very, very cute. But yeah, so watch movies together and watch TV.
Oh, that's cute. All right. How do I sign up for the clinic, or how do I get referred to the clinic?
You call us. That would be a good question. Now, if I had Deborah's phone number, I could give that to you. If you want it, I will be right back.
No, that we can email people later. Here, stay on the line here, Marcy.
So, the nurse coordinator is right next to me. But so Deborah Pickford, or through our department, central scheduling, Maria Panion, we can send out all of their information to you. So it's a quick phone call, and we do see patients on Thursdays. So we'd love to see whoever you are.
Okay, and I have the email of everybody that's asking these questions, so we can answer that for you directly. All right. Has the Survivorship Clinic looked at establishing relationship with diagnosed patients before they begin treatment? I believe this would help lessen anxiety as patients begin the journey by providing them with knowledge about what they were to experience.
So initially, when we started clinic, we had meant only to see patients post-treatment. But then I think it was one of our medical oncologists that said, how about seeing patients before treatment who have trouble? And Dr. Johnson said yes. And I was like, we're not prepared for this. But we have expanded, and we do think it's optimal that we see patients at least once before they start chemo and radiation. It really allows us to get needs addressed quickly if we have to. So if somebody's teeth aren't really great and may not make it through radiation, we can arrange to have that addressed. We can pair them with a speech language pathologist. If they have maybe they had a shoulder injury or they were in a car accident, we can start to give them exercises so that during radiation, they may not get worse. So it is the pattern that we really like to see people in is pre-treatment before radiation, 6 weeks after to about 2 months after they're done, and then yearly after that. And that should be mixed in with somebody's regular surveillance visits with their oncologist, their surgical oncologist, and their medical and radiation oncologist.
Okay. All right. So we've answered a lot of questions. We have a lot of that are a little bit more to the personal health, but I'm going to introduce one of these because I think that many of the listeners will be interested in this. So 1.5 years after surgery, 15 months after radiation, 9 months after last immunotherapy, some swallowing difficulty still. Was the best method not to not decline?
So this is huge. This question is so important. And, you saw evidence on our slides how it is important because people do tend to get more stiff over time. So today we are working primarily by using exercise. And we've increasingly embraced the potential that working with the exercises recommended by a physical therapist and the exercises recommended by a swallowing therapist may actually be synergistic in helping. So exercise for sure. Number two is that we're experimenting with a variety of topical agents that help with the dryness, and you know, with an effort to make that less of a burden for patients. And then the last thing is, frankly, is this is an incredible area for research. There's so much that needs to be done if we're ever hoping to truly move the needle on this problem.
So I think the other important thing is to note, if you feel like you've been kind of having similar trouble swallowing for a period of time and then you notice a change, that would be the time to reach out. Because if you're starting to notice a change, so something's getting a little bit more hard to eat, you could eat it before, but now you're having more trouble, or you're coughing more often, to really get back in with your providers and their speech language pathologists and have a swallowing assessment to see what's going on and to see if we can kind of tailor what you're doing at that point, because it may be different than what you needed right after treatment. So I think it's really important to know what to look for and to be able to kind of monitor your own symptoms and know when there's a change, because you're really the one who knows you're swallowing the best. And when people tell me they have trouble, a lot of the times that's one of the questions: is it getting different? Is it the same? Is it getting worse? Because we know most patients don't ever swallow quite the same again.
Okay. So here's a question. So I had tumors in my nose in 2011 treated with radiation and chemo. Currently, I had problems with allergies, dripping nose, and stuffy and increased mucus. Is this normal as a survivor?
So the answer is, I think to call it normal is perhaps a poor choice of words. But this kind of symptom is commonly encountered. It's commonly encountered. So anything that gets irradiated is going to be affected. And, you know, one of the things we've talked about is muscles and fibrosis. The other thing, of course, is the secretory apparatus. So the salivary glands are ruined by irradiation, so your saliva is abnormal. And of course, in the nose, there's many, many glands that make mucus. I mean, your nose runs. But if those glands have been irradiated, then they dry up and it becomes a different problem. So I'm not going to call this normal. I'm going to call this expected, post-treatment expectation. Yes.
Okay, I am going to continue with some of these questions. Some of them are you know, more specific to the person, but again, I think many people appreciate them. So one here is just, you know, I had my laryngectomy surgery at Montefiore and SLP support at UPMC Presby for many years, but now have Medicare and Highmark as a Plan B plan. And I'm not sure if you guys can answer this or not, but can I still take advantage of the UPMC survivorship team?
Yes.
Okay. Okay, that's a quick answer.
There's no problem.
If you have more questions, if you were to be interested in, when we give you the number for our nurse navigator, they can also help you with that. But yes, we do.
Okay. All right. So, and this question is, I'm 3 years out from surgery and radiation, still on pain medication. Mm-hmm. How long does the pain last?
Oh man, I wish I could tell you for sure. I think we don't understand pain as well as we should or well as we can. There's so many aspects that go into pain and what kind of pain you have. I would hope, without knowing, I can't tell you, but I'm sorry that you're still having pain.
Yeah. Okay.
Well, anything?
So once again, we'd like to understand pain better. I have to tell you that we have many patients who've tried medical marijuana and done other things to try to avoid opiates. And then I think therapy actually helps manage pain for some patients, just the stretching and the exercising. But it's, as Marcy intimates, it's so complicated and it's not an easy fix. It's a huge challenge. Marcy showed you earlier our data that suggested all these people who have neck disability. So neck disability manifests itself as pain. You can't turn your head. You have trouble rolling over in bed at night because your neck and your shoulders hurt. I mean, that's uncomfortable, and that's pain. So we're working at looking at different ways to help people deal with this. The most effective in 2021, in my opinion, has been exercise and stretching. So I don't mean lifting barbells. I mean stretching and moving the muscles so they don't become more stiff.
And I do think it depends on where your pain is. And there are some research studies going on right now to try to help manage pain and other symptoms. So since Lonnie has your email, if I can always provide that for you.
Okay, we'll be happy to do that. Is the Head and Neck Cancer Symposium canceled for this year?
Okay, yes, I'm sorry, whoever that is. I think obviously with the utmost caution, it was canceled, and we had some really, I think, great speakers lined up. So my hope is that we will be able to do it again next year, because it's one of the events that I look forward to. I look forward to having patients participate. I look forward to meeting other providers who are really passionate about what they do and just learning from people.
There's our poster.
Oh yeah. Look at all those beautiful people. They were ready to come.
Now an heirloom, never to be used.
It's sad for sure. Then, we're happy to bring this information this way, of course, but no, I think, those very important meetings have been very meaningful for a lot of practitioners and for patients as well.
So actually, Lonnie, there was a huge meeting, an international meeting held every 4 years, run by the American Head and Neck Society, which was to be in Chicago in July, next month. And we actually had 7 papers on that meeting. And it's a huge disappointment that had to be postponed. The American Head and Neck Society's meeting is going to be held now, I guess, in 2021. Mm-hmm. So we're all hopeful for that. But I don't have to tell you, the whole world has been derailed in one way or another, and we're optimistic to recover.
I do. So the Head and Neck Alliance, so I'm actually speaking, and we can share this information with you. So the Head and Neck Alliance was supposed to have a big patient-focused symposium in Chicago. And because of it being canceled also, they designed a webinar series. So it's really focused towards patients. I'm speaking first with one of our patients who's gracefully agreed to tell her story. So if anyone's interested in that, we can send it. It'll have information following up about lymphedema, exercise, and kind of the psychosocial effects of treatment. So it should be very interesting.
Okay. So here's another question. What is new, experimental, and being explored for maintenance and improvement of xerostomia? I heard mention of low-level laser therapy at Hillman.
Yes. So I know Dr. Johnson, they're in the process of publishing, Dr. Andy Klump, some results on that. And I haven't seen the paper in totality, but I think in the small group that they've actually reported on, they did seem to show a benefit.
So that's correct. Like everything in science, it will require, other people want to try it, other people want to review it, but they feel like they've made some progress, so that's a good thing.
Yeah, so and they're going to start up. They actually had to put it on halt because of COVID, but they are going to start treating patients with it again very shortly.
Okay. All right. This next question I'll answer says, I'd like to share this vital information with other providers at my institution. Can you provide copies of the slides and recording of the webinar? We can certainly send the recording of the webinar as a link to anybody interested in receiving this. And then one more question here. Please send information about the meeting at which Marcy will be speaking, Designed for Patients. Thank you. So how about we just, is that okay with you, Dr. Nielsen and Dr. Johnson, that we send that out to the attendees of today's webinar? Is that something that
I
everybody?
think it'd be fine. We have a link for that meeting in Chicago.
Okay.
The virtual meeting. Yeah.
That concludes our questions. If I did, we will look these over. If there's some that I missed, I apologize. As I said, I bounced around a little bit to hold some of the personal questions and that we can maybe answer better directly with you, which we will do. Thank you, everybody. Thank you for attending. Thank you for your time, participation. Thank you for your interest and support. Again, this is the kind of work we'd like to get involved with at the Eye and Ear Foundation. It's the kind of thing that we like to see that really advances care. And that's the goal of what we really want to do. What we try to do is to advance care so that we can continue to improve patient outcomes for the future. And this is the type of project that immediately has an impact because of the direct way that the care is being delivered. So thank you both. Thank you, everybody on the call. We'll look forward to more of these. Look forward to getting a survey for tomorrow, but also invitations to future webinars. We do this every other week. Have a nice afternoon.
Thank you.
Thank you, everybody.